Okay, folks. So last week I got finished with the EMCrit ED Critical Care Conference. And about that, I have some good news and I have some bad news. The good news, the conference was amazing. 550 residents and attendings from all around New York and the outlying areas. Steve Smith talking about EKGs blew folks away and petrified them. So that's the good news. The bad news? First of all, our camera person didn't show up, so there was no video of the conference. But that was okay, because I had my really expensive audio recorder in the back of the auditorium recording a feed of all of the conference audio. So no problem, just going to post the audio. No video, no worries. Until I went to the back of the auditorium at the end of the conference to discover that someone had knocked the recorder over and then slammed it between a door and the wall. So the recorder was in pieces. So no audio either. So I apologize. I can't give you any recordings of the conference to put up on the site. But there's always next year. And I'm going to try to duplicate a lot of the content. I'm going to try to re-interview the people we had at the conference. And along those lines, one of the lectures we do have a recording of is an amazing talk on BVM ventilation by a friend of mine named Ruben Strayer. Ruben runs a blog called Emergency Medicine Updates. Great stuff. Check it out. It was one of the EMCrit Hard 6 for 2011. And Ruben works with me in the Mount Sinai Division of ED Critical Care. And, Ruben and I often have debates about ED critical care topics. And what he put into words, and I think it's really the best description of how we interact, is that I'm on the cutting edge trying to pull the pack slightly closer to that line. He works a different way. He stays at the very back of the pack and tries to push folks over the line of substandard care to a baseline level of good care. So we're kind of working towards the same goal, but I'm kind of pulling the herd and Ruben's kind of pushing them, if you don't mind the herd analogy, for which I apologize. But he's a great guy, and I think you're going to love his talk. So the way we're going to do it is I'm going to play his talk. It's an audio and video. It lasts about 12 minutes. And then when that's done, I'm going to give you some of my own thoughts on BVM ventilation for another 5 minutes or so. So without further ado, Ruben Strayer on BVM ventilation. The mask side goes towards the face.
Ventilation is the most important skill in airway management. It is more important than laryngoscopy. If you are outstanding at laryngoscopy, but average at ventilation, you're in a bad position because you will encounter patients whose airways present challenges that you did not anticipate and are unprepared for. And these are invariably the patients who are most difficult to ventilate, so this leads to bad patient outcomes and a sad doctor. If you are average at laryngoscopy but outstanding at ventilation, things are good. Because when ventilation is successful, when we stay on the left side of this line, it is a happy day, regardless of what's happening or not happening with laryngoscopy. When you can ventilate, you can take as long as you need, perform as many airway attempts as you want. The pressure is off. It's a happy day. When you cross over to the other side of this line, when you cannot ventilate, you have entered the airway death spiral, where you are called upon to perform procedures that you are not comfortable with as quickly as possible, at the same time that your own heart rate is 150, your palms are sweaty, and your underwear is soiled. How many pairs of underwear you buy in your career depends mostly on how good you are at ventilation. Ventilation is the superstar skill in airway management, yet we spend a lot of time thinking about, talking about, and practicing laryngoscopy, and nearly ignore ventilation. Furthermore, when we're involved in an airway disaster or an almost airway disaster, we tend to consider this a failure of laryngoscopy rather than a failure of ventilation. We kick ourselves for not being better at laryngoscopy, for not having mastered some new airway toy. But this is like attributing the death of a trapeze artist to having poor mid-air acrobatic technique, rather than recognizing that the problem was his preference to perform without a net. In airway management, your skill in ventilation is your net. The most effective way to ventilate is, of course, through an endotracheal tube or tracheostomy tube, both of which bypass the soft tissues of the mouth and larynx to deliver air directly to the trachea. However, oral endotracheal intubation may be difficult or impossible, and performing a tracheostomy or cricothyrotomy is messy. That leaves two techniques, bag mask ventilation and supraglottic devices such as a laryngeal mask airway. We will not discuss the various percutaneous oxygenation techniques as they do not provide ventilation, only oxygenation if you're lucky. More importantly, I believe in cases where these techniques might apply, your time is better spent trying to get yourself out of the airway death spiral by performing cricothyrotomy. Bag mask ventilation is the most important emergency ventilation technique if for no other reason than it is universally available. It is the cornerstone of emergency airway management, the skill that keeps you out of the airway death spiral, and almost all of us learned how to do it wrong. This is how most of us learn to do bag mask ventilation. It is called the CE technique for the C your thumb and index fingers make around the inlet, and the E your last three fingers make around the patient's mandible. Most of you probably use this technique routinely, and it is the wrong technique. Every month or two, I'm involved in an airway management scenario and observe a provider bagging this way. As the saturation falls and everyone is freaking out and losing their mind, which is the easiest way to recognize the start of the airway death spiral, I courageously step in, use the correct technique, and the saturation comes up, and suddenly it's a happy day again. I'll then step out of the way and ask the person who was bagging before me to do it the way that I did it. And it works. The correct technique is easy. So why did we all learn the wrong technique? We learned the wrong technique because we learned to bag mask ventilate from anesthesiologists. Anesthesiologists use the CE technique because they bag patients as part of their routine, and it is important to an anesthesiologist to be able to bag alone, without assistance. So they need to be able to hold the mask to the face with one hand so they can use the other hand to bag. Being able to hold the mask to the face with one hand is not important to an emergency physician. An emergency physician wants to use the technique that is most likely to be effective on the first try, because when an emergency physician is doing bag mask ventilation, it is not part of a routine, calm, everyday start to another cholecystectomy. When an emergency physician is bagging, it's usually to avoid entering the airway death spiral. The CE technique is convenient to perform with one person, but it is not the most likely to be effective on the first try, especially for people who don't do it every day. It is therefore the wrong technique for emergency medicine. This is the correct technique for emergency physicians, the two thumbs down technique. In the two thumbs down technique, you use both your thumbs and palms to manipulate the mask, and you use both sets of your four fingers to bring the mandible anterior to the maxilla, which is a jaw thrust. There are several reasons why the two thumbs down technique is a superior technique. First of all, both hands are on the mask where they belong. Holding the mask to the face is the skill part of the procedure. Anyone can compress the bag. Your med student can compress the bag. The nurse can compress the bag. If your resuscitation bay is like mine, the patient in the next gurney over can compress the bag. Even an administrator can compress the bag. Anyone can compress the bag. You, the airway expert, need to have both hands on the mask. If it's just you, your patient, and a bag valve mask apparatus on a desert island, you still don't use the CE technique. You use the two thumbs down technique and compress the bag by positioning it in between your chicken wing and your body. When you use the two thumbs down technique, your palms surround the mask and you know exactly when and where there's an air leak. And you have maximum maneuverability to shift the mask to fix that air leak. Lastly, and very importantly, with the two thumbs down technique, you are using the strong muscles of your hands and arms. We evolved, or were intelligently designed, to grasp objects using four fingers against our thumbs. And holding the mandible and jaw thrust takes a fair amount of force, which you will not be able to do effectively for very long with your three weakest fingers. So if you take one message from this talk, please abandon the CE technique and use the two thumbs down technique for bag mask ventilation. but hopefully you'll take more than one message away from this talk. The second most important mistake emergency docs make when doing bag mask ventilation is they do not use oral and nasal airways. The tendency is to slam the mask on the face as quickly as possible, but you are more likely to effectively ventilate if you place oral and nasal airways. I promise, if you take 9 seconds to insert 3 airways, you will be glad you did. This means that you should have an appropriately sized oral airway and 2 appropriately sized nasal airways at the bedside whenever airway management is happening. Use an airway checklist to remind you to do this and to remind you of how to size these devices. Lastly, after you've placed your 3 airways, apply the mask with the bag detached. This cognitively separates the skill part of the procedure, holding the mask to the face, from the administrator part of the procedure, compressing the bag. Also, the bag just gets in the way. So, to summarize, you've realized that laryngoscopy is going to be harder than you thought. No problem. You come out early before the patient turns blue. You place your 3 airways. You separate the bag from the mask. And you place the mask on the patient with 2 thumbs down technique, gathering the mandible and performing a jaw thrust. And then you ventilate. So that's how an emergency physician should perform bag mask ventilation. Except that there is an even better way to perform emergency ventilation, and that is not to use the mask at all. In every airway algorithm, the step before cricothyrotomy is to place a supraglottic device like an LMA. This is often called a rescue device. You are using the LMA to rescue you from ineffective bag mask ventilation. This makes good sense, because placing an LMA is easier than doing bag mask ventilation, and an LMA is more likely to be effective than bag mask ventilation. An LMA delivers air directly to the glottis, so it's close to ventilating through an endotracheal tube, whereas doing bag valve mask ventilation is more like sticking your head out the window of a moving car. So why do we even bother with bag mask ventilation? Bag mask ventilation is harder to do and less effective than ventilating with an LMA. Why not skip the bag valve mask altogether and just place an LMA? There is literature to support this approach, specifically in obese patients, which some of you may have noticed can be difficult to intubate and difficult to ventilate using bag mask technique. I recommend that you keep the right size LMA ready to go, and when laryngoscopy fails, proceed directly to placing an LMA. Once ventilation is established through the LMA, you can remove the LMA and commence your second airway attempt, or intubate through the LMA. So, in summary, remember that in airway management, ventilation is your safety net. The CE technique is great for the OR, but has no business in the ER. Use 2 thumbs down. Place your airways and separate the mask from the bag prior to commencing bag mask ventilation. Or do even better by skipping bag mask ventilation entirely and moving directly to the LMA. But only in patients without airway reflexes. Thanks to my superstar residents. Email me with any questions.
Okay, so really, really good stuff, I think, and I think you'll agree. Just want to give you some of my own thoughts on BVM ventilation. I have a whole lecture that encompasses this. Some of you have heard it's called the laryngoscope. It's a murder weapon. It's what I do for a lot of the grand rounds. So if I ever come into your place, you'll probably hear the whole lecture. But just briefly, the first thing I want to mention is Ruben basically said that the CE technique is okay for the OR and not okay for emergency medicine. It's probably not even okay for the OR. I'm going to put a study in the show notes showing even anesthesiologists did a fairly poor job of one-hand mask ventilation compared to 2 hands. Everyone out there is better with 2 hands. 1 hand might get you by, but it's really not going to work well in anyone's hands, even very experienced hands. The next thing is, as important as holding the mask properly is the bag portion of BVM ventilation, meaning it needs to be squeezed very slowly and not very often. It needs to be squeezed about 10 times a minute. And anything more than that will do absolutely nothing for oxygenation. Absolutely nothing for oxygenation. Essentially, all you need is 2 breaths a minute, for oxygenation. Everything else is just bonus. Maybe it'll give you some decrease in your CO2, but that's not really the issue during these intubation scenarios. So really you need 2 breaths a minute. I'm not advocating 2. I'm telling you to do 10. Don't do 60. Don't do 120. And if you want to hear more about the reasons why you only need 2 breaths a minute, I could go into that in that laryngoscope as a murder weapon lecture, or you could read my papers on the subject. But for now, just understand that you should only be squeezing it 10 times a minute. But as soon as the adrenaline's flowing in you and your team, what seems like 10 times a minute is actually the 120 times a minute. You have no real perception of time during stressful circumstance. It all disappears, time slows down, and you think you're given really slow rates of BVM ventilation. You're actually going insanely quickly. So you need an external moderator of ventilation timing, or whoever squeezing your bag does, meaning either you need a little blinking red light, which is what the FIDNY, the Fire Department of New York paramedics, have on their BVMs. It's a cheap little LED that blinks once every 5 seconds. Or use the Mississippis, say 1 Mississippi, 2 Mississippi, and at every 5 Mississippi give a breath, or every 6 Mississippi, but have some external moderator, external marker of time, or there's no way you'll be doing 10 to 12 times a minute. You'll be doing that 60 to 120. Now, let's say you were doing that all right. You were doing 10 breaths a minute, nice slow breaths, 2-hand mask seal, and all of a sudden you look up at the pulse ox, and after that first intubation attempt, it was 65%. Patient had precipitously desaturated. And now you look up again, and it's now even lower. Now, your first instinct, whether it be on a conscious or subconscious level, is to bag quicker and harder. But that is not going to make things better. Either the breaths are going in or they're not. If they're going in, you only need 2 of them a minute. Anything more than that's not helpful. And you bagging quicker and harder will just make the patient's stomach inflate, and eventually they're going to puke, and then it's pretty much game over for that BVM and for that ventilation going into the lungs. So do not speed up. Why is the pulse ox not rising? Well, there's 1 or 2 reasons. Either the breaths are not going in, or you're experiencing pulse ox lag. And pulse ox lag is a subject I talk about extensively in the paper that's coming out in the Annals of Emergency Medicine I wrote with Rick Levitan, and that'll immediately go up on the blog as soon as it's published. But pulse ox lag, in short, is that the pulse ox is not giving you a representation of the present. What you see when you look up on the pulse ox and you see a number there is not the present, it's the past. It's the past. And how far in the past is directly dependent on the patient's cardiac output. So a normal patient, if you see 100% up there on your pulse ox, that means 30 seconds ago, thereabouts, they were at 100% sat. 30 seconds ago, they were at 100% sat. They might not be 100% right now. 30 seconds ago, they were. As your cardiac output gets worse, as you're a sicker patient, that lag gets longer. And it might be a minute and a half in the past. Now, how does this translate to your BVM ventilation? Well, it means that when you look up at the 65 and you have a sick patient, it might have been 90 seconds ago they were at 65 during your intubation attempt. And then you kept on going until it actually registered on the pulse ox. Now, this means you could be giving perfect BVM ventilation and getting those breaths in, and that pulse ox might still drop or not rise because you have to wait another minute and a half before you're going to see the results of your BVM ventilation. And this is scary, and this is petrifying because the number is not getting better. You're scared the patient's going to go into cardiac arrest, and naturally you start bagging quicker and harder, even if you're not aware of that, even if you know consciously that's a bad idea. So how do you counter this situation? How do you know that those breaths are going in? And therefore, even if the pulse ox isn't rising, you know it will if you just wait out a little bit. Well, this is my big tip for this podcast. Every time you are using a BVM, you should have an end-tidal CO2 sensor on your BVM. Don't just use that waveform end-tidal CO2 for it to confirm the endotracheal tube after you place it. Put it on the BVM between the bag and the mask before you even start your intubation. Put it right there. It fits just perfectly between your bag and the mask, and leave it there, ready in case you need to use the BVM. Now, what does this do for you? Well, if you do have to give BVM ventilation to a patient, you will have immediate feedback that that breath has gone in. If you give a breath and then the patient passively exhales and you see waveform end tidal CO2, it means that breath with that high FiO2 got into the lungs, pushed out during the exhalation CO2. And each time you give a breath, if you see that waveform, it means your positioning of the patient is good and they are getting oxygen. And if that is true, then they will come up on their saturations. They will come up on their saturations. And you don't need to bag harder or quicker. The only reason they would not come up on their saturations is if they've developed massive shunt during your intubation attempt. But that's not usually how it plays out. It usually plays out the patient is shunted beforehand. But that's a whole nother lecture. But you know your BVM ventilation is working if you have waveform end tidal CO2 each time you give a breath. If you don't have waveform end tidal CO2, you must reposition. If you haven't already done what Ruben's advocated, you have to put in 3 airways, an oral and 2 nasals. And if you're still not getting waveform end tidal CO2 and the patient has a pulse, then you need to put an LMA in because your BVM technique is not working out. Every time you use that BVM, I say have the waveform end tidal CO2 on the BVM. You should have it for every intubation already. If you don't believe that, listen to the NAP4 podcast. But you should also have it on your BVM and check every breath you give with that BVM with waveform end tidal CO2. All right, last tip. The way to eliminate all these problems is to not use the BVM at all. Now, Ruben says use an LMA. I'd go one step further and say that don't use the LMA if you don't have to. I use it as a rescue device. I kind of disagree with Ruben on this one, though I see his point. It's a fantastic point. It's a point also made by Darren Brody out in New Mexico. But I'd say do it a little different. I have a ventilator standing by every time I do an intubation at the bedside. It's there. It's already there. I have it turned on and set to settings that allow perfect BVM ventilation. And all I do is I take the mask from the bag valve mask and I attach it to my ventilator tubing. And now I have a device that gives perfect respiratory rate. It gives 100% FiO2. It gives ideal PEEP. It gives a perfect flow rate so that those breaths are given nice and slow. I could hold a 2-hand mask seal myself. I don't need anyone else to help with that bag because there is no bag. I have a machine doing the work and it does it perfectly. If you want to see what I'm talking about, just go to the show notes. I've embedded a video showing how to use a ventilator as a better form of BVM. And I call it the vent as a bag. And that's also part of that laryngoscope as a murder weapon talk. I don't want to go into that in any further detail. We're getting to the point where I have to say goodbye. We're hitting that 20-minute mark. So I want to hear what you think of this podcast in the show notes. Come, leave your comments. Let me know what you think, and I will forward those to Ruben as well. An incredible amount of stuff is coming out in the next few months on the EMCrit podcast and blog. I'm going to be offering CME. I'm going to have some guest bloggers and a lot of other great stuff. So stay tuned. This is going to be the best year ever for the EMCrit podcast. All right, this is Scott Weingart saying bye-bye.